Would you trust just anyone to inject a drug directly into the brain? Neither would we. In this video, you'll learn the exact step-by-step protocol for preparing life-saving intraventricular drugs used in CNS infections, meningitis, brain tumors, and more. Why does it matter? Because one wrong step can lead to seizures, toxicity, or worse. Whether you're a pharmacy student, ICU pharmacist, or neurosurgery fellow, this guide could literally save a life. So grab your gloves and let's compound with confidence. This is intraventricular drug prep, done right. Let's start with the million-dollar question. Why does intraventricular drug compounding even matter? Because most drugs, no matter how powerful, can't cross the blood-brain barrier. This shield is the brain's natural defense, but it also blocks life-saving medications from reaching the central nervous system when we need them most. Intraventricular administration bypasses this barrier entirely. By delivering the drug directly into the cerebrospinal fluid, we get high concentrations right where the infection or tumor is, with minimal systemic exposure. This route isn't just useful, it's essential for treating deadly ventriculitis, meningitis, intracranial abscesses, brain tumors, or even hemorrhagic clots blocking the ventricles. And here's the thing. This isn't your typical IV preparation. We're talking about direct brain exposure, where 1 microgram too much, or a single contaminant, could trigger seizures, brain swelling, or death. That's why intraventricular drug compounding demands laser-sharp accuracy, sterile perfection, and respect for every drop. Because in this setting, good enough is never good enough. Before you even touch a vial, draw a dose, or think about injecting anything into the central nervous system, you need to master the golden rules of sterile compounding. This is where precision meets protection. Rule number 1. Work only in a certified cleanroom, using a Class II biosafety cabinet or ISO 5 laminar airflow hood. This isn't just best practice. It's the bare minimum standard to protect the brain from contamination. Sterile garbing is non-negotiable. Rule number 2. Suit up like you mean it. That means full sterile garbing. Gown, gloves, cap, mask, shoe covers, and above all, impeccable hand hygiene. This is your shield, your barrier between life-saving medication and microbial catastrophe. Rule number 3. Before piercing any vial, disinfect the rubber stopper with 70% isopropyl alcohol. Wipe firmly, in one direction, and let it air dry completely. Because bacteria love shortcuts, and you're not giving them one. Rule number 4. Only use preservative-free diluents. Normal saline or dextrose 5% in water, but no preservatives, ever. Why? Because intraventricular space is delicate. Even trace preservatives like benzyl alcohol can cause chemical meningitis or seizures. And rule number 5. Inspect everything. Hold each syringe or vial to the light. If you see cloudiness, crystals, discoloration, or particles, toss it. When it comes to brain exposure, if in doubt, throw it out. Remember, aseptic failure equals neurologic disaster. Follow these 5 rules, and you don't just protect the drug. You protect the brain, the patient, and your license. Alright, now that you're in a sterile environment and properly garbed, let's talk about what separates a safe brain injection from a dangerous one: reconstitution and dilution. First, always follow the manufacturer's instructions for reconstituting lyophilized powders. That's your blueprint. Some drugs use sterile water. Others require preservative-free normal saline. The exact diluent and the amount matters. Don't guess. Don't freelance. Once reconstituted, your next move is precision. Use a sterile syringe to withdraw the exact dose, down to the last tenth of a milligram. This isn't IV compounding. There's no dilution buffer in the bloodstream. Every microgram you inject goes straight into the brain. Now here's the golden rule for intraventricular preparation. Always dilute your final dose to a total volume of 2 milliliters. Why? Because the ventricles and cerebrospinal fluid space are tiny. Exceeding 2 milliliters can spike intracranial pressure, cause headaches, nausea, or worse, herniation. Dilute your dose using only preservative-free normal saline or 5% dextrose solution in water, depending on the drug. Never use multi-dose vials. Never use bacteriostatic water. Even trace preservatives can cause seizures, brain inflammation, or chemical meningitis. Once you've got the dose diluted in 2 milliliters of sterile, preservative-free fluid, inspect the syringe one more time. No bubbles. No particles. No cloudiness. This is your final product. A perfectly prepared dose, ready for the most protected space in the human body, the brain's ventricular system. Coming up, labeling and storage best practices. You've compounded the drug. You've double-checked your dose. Now comes a step that's just as critical, yet often rushed or overlooked. Labeling and storage. Because what isn't labeled clearly might be injected blindly. And when it comes to the central nervous system, that's a risk you can't afford. Start with clear, legible labeling. That means 1. Drug name. 2. Exact dose. 3. Concentration per milliliter. And 4. Date and time of preparation. Every time. No exceptions. Add a bold warning. For intraventricular use only. This isn't just good practice. It's life-saving. It prevents medication errors, especially when multiple routes are used in critical care. Before storage or administration, perform one final visual inspection. Hold the syringe against a well-lit background. Check for 1. Cloudiness, 2. Crystals, 3. Discoloration, and 4. Particles or bubbles. If you see anything off, discard it. Period. Now, storage. Intraventricular preparations are highly sensitive. Use the dose within 4 hours at room temperature, or refrigerate and use within 24 hours max. After that, discard. No debate. Because this isn't a muscle. This isn't a vein. This is direct brain exposure. And when the drug goes into the ventricles, there's no such thing as probably safe. Only definitely safe, or don't administer at all. Up next, administration and clamp protocol. You've compounded your intraventricular dose with care. You've labeled and stored it properly. Now comes the moment that connects science to patient survival. Administration. These medications are administered either via an Ommaya reservoir, a dome-shaped access port implanted under the scalp, or via an external ventricular drain, also called an EVD. But no matter the access route, one rule stays the same. After injection, you must clamp the system. And not just for a few minutes. We're talking a minimum of 1 full hour. Why? Because cerebrospinal fluid doesn't circulate rapidly. That clamp time allows the medication to disperse evenly throughout the ventricular system. So it reaches the target tissue, and doesn't just pool in one spot and cause localized toxicity. Before and after administering the drug, you may need to gently flush the catheter with 0.5 to 1 milliliter of preservative-free normal saline. This clears the line and ensures the full dose enters the CSF. But always flush slowly and cautiously. No pressure. The brain doesn't like surprises. Once administration is complete, dispose of all syringes and needles in a clearly labeled sharps container. Never recap. Never reuse. Sterility isn't optional, especially not when the brain is involved. To recap: 1. Administer via Omaya or external ventricular drain. 2. Clamp for at least 1 hour. 3. Flush with preservative-free normal saline if needed. And 4. Dispose of all materials correctly and immediately. Coming up next, monitor and manage safety. You've compounded the dose. You've administered it into the most protected space in the body, the ventricular system. Now the most critical part begins: monitoring and managing patient safety. Why? Because the margin between effective treatment and devastating toxicity in the central nervous system is razor thin. First, watch for neurotoxic reactions. We're talking about 1. Seizures. 2. Altered mental status. 3. Signs of chemical meningitis. And 4. Local ventricular irritation. These can develop rapidly, sometimes within hours of administration. Next, track patient vitals continuously. Look for early signs of neurological distress, autonomic instability, or increased intracranial pressure. Subtle changes can be the first red flag. Also monitor CSF output. Is it cloudy? Has the flow slowed down? These could be signs of infection, obstruction, or worsening inflammation. And here's where therapeutic drug monitoring, or TDM, becomes your safety net. Some intraventricular drugs build up in CSF quickly, and toxicity can sneak up before symptoms show. For the following drugs, therapeutic drug monitoring isn't optional, it's essential. 1. Vancomycin. 2. Gentamicin and amikacin, that is the aminoglycosides. 3. Amphotericin B. 4. Ganciclovir. And 5. Foscarnet. Monitor both serum and CSF levels where protocols exist, especially in prolonged therapy. Balancing effectiveness and neurotoxicity in the brain requires precision, vigilance, and collaboration with your neurocritical care team. Remember, intraventricular success equals compounding plus monitoring plus clinical judgment. Because intraventricular success isn't just about the compounding technique. It's also about what you do next. Monitor closely, react early, and never ignore the smallest signal. Coming up, drug profiles. What to know before you prepare. Now that you know how to compound intraventricular medications safely, let's break down the most commonly used intraventricular antibiotics, starting with the 4 essentials: vancomycin, gentamicin, amikacin, and colistin. First up, vancomycin, the go-to for gram-positive meningitis, including MRSA. The typical dose, between 5 and 20 mg per day, depending on the infection and CSF levels. Vancomycin usually comes as a 50 mg per milliliter stock after reconstitution. Using strict aseptic technique, withdraw the precise dose. For example, 0.2 milliliter for a 10 mg dose. Then, dilute to a total volume of 2 milliliters using preservative-free normal saline or 5% dextrose solution in water. Remember, TDM is crucial. Levels too high can lead to neurotoxicity, hearing loss, or seizures. Next, gentamicin, a potent aminoglycoside for gram-negative coverage. Typical intraventricular dose ranges from 4 to 8 mg daily. It usually comes as a 10 mg per milliliter solution. So, for a 6 mg dose, withdraw 0.6 milliliter, and again, Dilute to 2 ml total using preservative-free normal saline. Gentamicin can accumulate in the CSF. So use therapeutic drug monitoring and monitor closely for signs of ototoxicity or vestibular toxicity. Now we've got amikacin, another aminoglycoside, often used when resistance to gentamicin is suspected. A common intraventricular dose, around 30 mg. Amikacin comes as a 50 mg per milliliter stock solution, so you'll draw up 0.6 ml for a 30 mg dose. Dilute it to a final volume of 2 ml with preservative-free normal saline. Administer slowly, and clamp the EVD for at least an hour post-injection to ensure even drug distribution through the CSF. Last in this set, colistin, a last resort drug for multi-drug resistant gram-negative organisms. Dosing is complex, but typically around 10 mg of colistin base activity is used. Colistin must first be reconstituted exactly as per the manufacturer's label, typically using sterile water for injection. Once reconstituted, measure the correct dose and dilute it to 2 ml using preservative-free normal saline. Watch for neurotoxic side effects like paresthesias, confusion, or apnea, especially with repeated dosing or poor CSF clearance. These 4 antibiotics are powerful tools, but with great power comes great precision. Stick to exact doses, use preservative-free components, and never let your technique slip, because when you're injecting into the brain, there's no second chance. Let's continue our deep dive into intraventricular antibiotics, with 4 more heavy hitters you'll encounter in critical neuro cases: tobramycin, ceftriaxone, cefotaxime, and meropenem. First up, tobramycin, another aminoglycoside often reserved for tough gram-negative infections. The typical intraventricular dose ranges from 5 to 20 mg per day. It's supplied as a 40 mg per milliliter stock solution. To prepare, withdraw the exact dose. Let's say 0.25 ml for a 10 mg dose. Then carefully dilute to a final volume of 2 ml using preservative-free normal saline. Like other aminoglycosides, TDM is essential, especially to avoid neurotoxicity and hearing loss. Next, ceftriaxone, a broad-spectrum cephalosporin often used for meningitis caused by Streptococcus, Haemophilus influenza, or Neisseria. Start with a 1 gram vial and reconstitute it with 10 ml of sterile water for injection. This gives you a 100 mg per milliliter solution. Then, withdraw the required amount. For example, 50 mg is 0.5 ml, and dilute up to 2 ml with preservative-free diluent. Ceftriaxone can precipitate in solution, so inspect carefully before use. If it's cloudy or forms crystals, discard it immediately. Now let's move to cefotaxime, another cephalosporin with excellent CNS penetration. It's often supplied as a 100 mg per milliliter solution after reconstitution. Just withdraw the precise dose you need, for example, 40 or 50 mg, and dilute it up to a total of 2 ml using preservative-free normal saline or a 5% dextrose solution in water. Simple, clean, consistent. Cefotaxime has limited stability once diluted, so aim to prepare and administer it immediately. No batching. Last on this slide, meropenem, a powerful carbapenem for resistant gram-negatives and CNS infections. Start with a 500 mg vial, and reconstitute it with 10 ml of sterile water. This gives you a 50 mg per milliliter solution. Then, Draw up the desired dose, commonly 10 to 50 milligrams, depending on severity, and always dilute to a final volume of 2 milliliters. Be extremely cautious. Meropenem is neurotoxic at high doses. Start low, monitor closely, and adjust based on patient response and CSF levels when possible. With these antibiotics, exact technique is everything. Precision dosing, preservative-free dilution, and a crystal clear understanding of how each drug behaves in the brain. Now let's talk about the next tier of intraventricular medications. Those reserved for tough-to-treat infections, fungal invasions, or drug-resistant bugs. These include Amphotericin B, linezolid, and rifampin. All powerful, all requiring extreme precision. Let's start with Amphotericin B, your frontline agent for cryptococcal meningitis or fungal ventriculitis. But here's the catch. It's incredibly neurotoxic if overdosed. So dosing is ultra low, usually 0.01 to 0.5 milligram. Prepare it at 1 milligram per milliliter in 5% dextrose solution in water. Then, carefully withdraw your dose. For example, 0.5 milliliter for 0.5 milligram. And always dilute to a total of 2 milliliters using 5% dextrose solution in water only. Never normal saline. It precipitates. Because of its instability and potency, Amphotericin B must be prepared fresh. Inspect thoroughly. No particles. No discoloration. No shortcuts. Next, linezolid, used for resistant gram-positive CNS infections like VRE or MRSA. While not FDA labeled for intraventricular use, it's sometimes used off-label under specialist protocols. Linezolid is typically supplied as an IV concentrate at 2 mg per milliliter. To prepare for intraventricular dosing, often around 10 mg, withdraw 5 milliliters of the concentrate, then dilute and adjust down to 2 milliliters total volume using preservative-free diluent. This one's important. Linezolid protocols vary between institutions. Some require specialized compounding workflows or pH-adjusted solutions. Always confirm with current neurosurgical or infectious disease guidance. Finally, rifampin, a key agent for tuberculous or device-related meningitis. After reconstitution, rifampin is usually 60 mg per milliliter. The typical intraventricular dose, 10 to 20 mg. Draw the needed volume. Let's say 0.33 milliliter for 20 mg. And dilute to a final volume of 2 milliliters using preservative-free normal saline. Rifampin is bright orange-red and can stain CSF drainage systems. It's also irritating to neural tissue, so inject slowly and monitor closely post-administration. These drugs operate on the edge of modern neuropharmacology. They save lives, but only if compounded, diluted, and administered with absolute care. Up next, antivirals and A.D.O.T. Final protocols. We've covered antibiotics, antifungals, and specialized agents. Now let's close with 3 powerful tools used in viral CNS infections and ventricular obstruction: ganciclovir, foscarnet, and A.D.O.T. Each has unique handling needs, and no room for error. First, ganciclovir, used for CMV ventriculoencephalitis, especially in immunocompromised patients. After reconstitution, it's typically supplied as a 5 mg per milliliter stock solution. To compound, withdraw the exact dose, usually 5 to 10 mg, or 1 to 2 milliliters. Then dilute to exactly 2 milliliters total volume using preservative-free normal saline or 5% dextrose solution in water. Important: ganciclovir is highly unstable and prone to crystallization, especially in cooler environments. Use immediately after dilution, and inspect thoroughly before dosing. Next, foscarnet, another antiviral for resistant CMV or HSV in the CNS. It comes ready as a preservative-free stock solution, typically at 24 mg per milliliter. Here's how to compound. Measure the required dose, often 20 mg or less. Then dilute to 2 milliliters total volume using preservative-free normal saline only. Foscarnet can be very irritating to the meninges. Administer slowly, and monitor for any signs of headache, dizziness, or seizures following installation. Finally, alteplase, a clot-dissolving agent used for clearing intraventricular hemorrhage and restoring CSF flow. This isn't an antimicrobial. It's a thrombolytic, and it's treated with absolute caution. To compound, reconstitute a standard vial to 1 mg per milliliter. Withdraw 1 mg, then dilute to 2 milliliters total volume using preservative-free normal saline. Instill slowly via EVD, making sure the catheter is patent. Then, clamp the drain for exactly 1 hour. This allows the drug to contact and act on the clot without draining away too early. Due to its bleeding risk, alteplase must only be used under strict neurocritical care supervision, and only with established protocols in place. These agents are powerful, but they're also unforgiving. Whether you're fighting a viral infection or restoring CSF flow, your compounding accuracy isn't just clinical, it's neurological. It's personal. Let's zoom out for one moment and bring all the pieces together. This is your quick prep summary table, the fast, visual roadmap that keeps your workflow tight, standardized, and safe. Almost every intraventricular drug, from vancomycin to ganciclovir, follows this same clean format. 1. Stock concentration, clearly labeled on the vial. 2. Precise dose withdrawn using a sterile syringe. 3. Diluted with preservative-free normal saline or 5% dextrose solution in water. And 4. Final volume, always 2 milliliters. Remember, 2 milliliters equals consistent intracranial pressure management. This uniform 2 milliliters volume is more than convenience. It's about maintaining stable intracranial pressure, minimizing CSF disruption, and ensuring the drug distributes evenly throughout the ventricles. And here's the real power of standardization. When every drug follows the same structure, your team moves faster, makes fewer errors, and responds confidently under pressure. This isn't just a summary. It's your compounding blueprint. Use it. Memorize it, rely on it, because in the world of intraventricular dosing, consistency isn't optional. It's life-saving. You've made it through the most advanced route in neuropharmacology. And now it all comes down to this, the final preparation checklist. 1 list, 7 steps, 0 room for error. Step 1, ISO 5 clean hood. Always compound inside an ISO Class 5 laminar airflow hood, located in a certified cleanroom environment. This is your sterile zone, protected like the operation room. Step 2, alcohol disinfected vials. Before puncturing any vial, scrub the rubber stopper with 70% isopropyl alcohol for at least 10 to 15 seconds. Let it air dry. No shortcuts. This is your first defense against contamination. Step 3. Accurate reconstitution and dilution. Follow the manufacturer's label to the letter when reconstituting lyophilized powders. Then, withdraw your exact dose, and always dilute to a final volume of 2 ml using preservative-free diluents only. That 2 ml rule, it's non-negotiable. Step 4. Correct labeling. Clearly label the syringe or delivery vial with drug name, dose, final concentration, and date and time, and most importantly, mark it for intraventricular use only. No ambiguity, no confusion. Step 5. Inspect for particulates. Before administration, inspect visually for particles, discoloration, or cloudiness. If it's not perfectly clear, don't inject it. Full stop. Step 6 to 1 hour post-dose clamp. After administration, clamp the EVD or Omiya system for at least 1 hour. Why? To let the medication circulate evenly through the CSF. If you skip this, the drug can drain away before it works. Step 7. Monitor for neurotoxicity and track CSF or vitals. Watch closely for neurotoxic symptoms like seizures, restlessness, or altered consciousness, especially with aminoglycosides, amphotericin, or antivirals. Log CSF output. Monitor vitals hourly. Use therapeutic drug monitoring where appropriate. This isn't just a checklist. It's your patient's last line of defense. When you're injecting straight into the brain, there's no room for good enough. There's only exact, sterile, safe. Let's bring it all together with this intraventricular drug compounding summary table, your quick reference guide for exact dosing, dilution, and handling of key intraventricular medications. Starting with vancomycin, typically compounded from a 50 mg per milliliter stock. The adult dose ranges from 5 to 20 mg, which means withdrawing 0.1 to 0.4 milliliter, then diluting up to 2 milliliters total with preservative-free saline or 5% dextrose solution in water. Monitor CSF drug levels closely. And remember, neurotoxicity is real, and you must clamp for at least 1 hour post-dose. Next, gentamicin, another high-stakes antibiotic. It comes at 10 mg per milliliter, with a daily dose of 4 to 8 mg. You'll withdraw 0.4 to 0.8 milliliter, then top up with preservative-free normal saline to make 2 milliliters. Because of its risk for ototoxicity and nephrotoxicity, therapeutic drug monitoring is strongly advised. Vancomycin is more concentrated, 50 mg per milliliter stock, with doses ranging widely from 5 to 50 mg. Withdraw anywhere from 0.1 to 1 milliliter, and again, dilute to 2 milliliters using preservative-free saline. Always use a preservative-free vial, and monitor CSF levels when possible. Now, colistin, a last resort agent for multi-drug resistant bugs. Supplied as a 150 mg vial, you'll reconstitute it per the manufacturer's instructions. The typical intraventricular dose is about 10 mg, which you'll convert and withdraw, then dilute to 2 milliliters with preservative-free normal saline. Be aware, colistin has significant neurotoxicity potential. Tobramycin is next, supplied as 40 mg per milliliter stock, with daily doses between 5 and 20 mg. That's 0.125 to 0.5 milliliter withdrawn, diluted to 2 milliliters total. It's similar to gentamicin, but don't forget, overdosing can lead to seizures. Ceftriaxone comes as a lyophilized vial. Once reconstituted, it yields 100 mg per milliliter. Withdraw 0.1 to 1 milliliter depending on your target dose. Then bring it up to 2 milliliters using preservative-free normal saline. Make sure to use it within 6 hours of reconstitution to maintain potency. And finally, cefotaxime, also prepared to 100 mg per milliliter after reconstitution. Withdraw your dose from 10 to 100 mg or 0.1 to 1 milliliter, and again, dilute to 2 milliliters. It's stable for about 24 hours under refrigeration, but always check for particulates or discoloration before dosing. Each of these drugs follows the same core rule: accurate dose, preservative-free dilution, final volume equals 2 milliliters. It's this uniform protocol that keeps your compounding process safe, predictable, and scalable, no matter which agent you're preparing. Now, let's cover the critical details for some of the more specialized and high-impact agents used in intraventricular therapy. This is your go-to quick reference for Meropenem, Amphotericin B, linezolid, rifampin, ganciclovir, foscarnet, and alteplase. Starting with Meropenem, this broad-spectrum carbapenem is supplied as a 50 mg per milliliter solution. Typical adult doses range from 10 to 50 mg daily, which means withdrawing 0.2 to 1 milliliter from the stock. It's diluted in preservative-free normal saline to a final volume of 2 milliliters. Important: use immediately after reconstitution, as Meropenem is unstable at room temperature and loses potency quickly. Next, the powerful antifungal Amphotericin B, available as a 1 mg per milliliter solution in 5% dextrose solution in water. Due to its narrow therapeutic window, doses range from 0.01 to 0.5 mg. That's 0.01 to 0.5 milliliter withdrawn and diluted with preservative-free 5% dextrose solution in water only. Never dilute with normal saline. It can cause precipitation. And be extremely cautious. Amphotericin B is highly neurotoxic, so precise dilution and slow administration are mandatory. Linezolid, an investigational agent for CNS infections, comes as a 2 mg per milliliter IV solution. The typical dose used here is about 10 mg, meaning you'll withdraw 5 milliliters and then concentrate it down to a 2 milliliters final volume with preservative-free normal saline. Keep in mind, clinical data is limited and CNS penetration varies. Use with careful monitoring. Rifampin is a potent adjunctive therapy dosed at 10 to 20 mg. Its stock concentration is 60 mg per milliliter, so you'll withdraw roughly 0.17 to 0.33 milliliter and dilute to 2 milliliters. Handle with care. Rifampin stains everything it touches, so wear gloves and protect surfaces. It's rarely used alone but may be invaluable in combination regimens. Ganciclovir is the frontline agent for CMV-CNS infections. Supplied as a 5 mg per milliliter preservative-free stock, typical doses range from 1 to 5 mg, or 0.2 to 1 milliliter withdrawn. Dilute to the familiar 2 milliliters final volume with preservative-free normal saline. Always confirm you're using a preservative-free formulation to avoid toxicity. Foscarnet is used infrequently but plays a critical role in resistant viral infections. Its preservative-free stock concentration is 24 mg per milliliter. Doses generally range from 5 to 10 mg, meaning you withdraw between 0.2 and 0.4 milliliter and dilute to 2 milliliters with preservative-free normal saline. Watch for electrolyte imbalances during therapy. This drug demands close patient monitoring. Finally, the clot buster Alteplus, used primarily for EVD catheter clot clearance. Available as 0.5 mg per milliliter in a 2 ml vial, the usual dose is 1 mg, which is the full vial volume. Instill directly into the EVD, then clamp for 1 hour to allow the medication to work. Sterile technique is non-negotiable to prevent infection. Remember, always use preservative-free diluents. Maintain a final volume of 2 ml for safe intracranial pressure control. Follow drug-specific stability and handling precautions precisely. These principles keep your compounding process safe, precise, and effective, the cornerstone of successful intraventricular therapy. And that's a wrap. Remember your A.D.O.T mantra. Aseptic technique, dilution strictly to 2 ml, and observe the full clamp time. The 3 pillars that keep your intraventricular compounding safe and effective every single time. Want to master this process even faster? Check out the free printable checklist linked right in the description. Your ultimate bedside companion for flawless compounding. If you found this guide helpful, smash that like button, and drop a comment below telling us which intraventricular drug you compound most often. We love hearing from pharmacy pros in the trenches. And don't forget, hit subscribe and ring that bell icon so you never miss another pro tip designed to level up your pharmacy skills. Thanks for watching. Stay sharp, stay sterile, and keep saving lives, one dose at a time. I will see you in the next one.